Hello, this is Dr. Thomas. Today I'm going to be presenting another important case study 14. Disclaimer. Patient presentation. We have a 70-year-old female who is brought to the emergency department by her family due to decreased consciousness over the past 2 days. She has been progressively lethargic, confused, and has not eaten or taken her medications for the past 3 days. The family reports that she has been experiencing increasing fatigue, cold intolerance, and weight gain over the last few months. Medical and relevant surgical history. She was diagnosed with hypothyroidism 15 years ago on levothyroxine, but with poor compliance. Has a history of hypertension diagnosed 10 years ago, managed with lisinopril and hydrochlorothiazide. Also has a history of congestive heart failure diagnosed 5 years ago, New York Heart Association Class 2 symptoms on furosemide and carvedilol. No previous surgical history. She had a recent upper respiratory tract infection 2 weeks ago and was treated with over-the-counter medications. Physical examination findings. The patient is uptended, hypothermic, and in obvious distress on general examination. Vital signs showed a temperature of 95.2, heart rate of 48, blood pressure of 90/60, respiratory rate of 10 breaths per minute, oxygen saturation of 88% on room air. Skin is cool, dry, and pale with non-pitting edema of the face and extremities. Head, eyes, ears, nose, and throat examination showed periorbital puffiness, dry coarse hair, and eyebrows thinning. Neck examination showed no goiter, neck veins were flat. Cardiovascular system examination showed that the patient is bradycardic with faint heart sounds and no clinically significant murmurs. On chest examination, breath sounds were diminished bilaterally at the bases. Abdomen soft, non-tender, bowel sounds diminished. On central nervous system examination, patient appeared to have depressed mental status, Glasgow Coma Scale of 8, and had delayed deep tendon reflexes. Relevant investigations. Complete blood count showed WBC count of 6,500, hemoglobin of 10.2, platelet of 180,000. Basic metabolic panel showed moderate hyponatremia with serum sodium of 128, potassium of 4.5, chloride 92, bicarbonate of 28, blood urea nitrogen of 32, creatinine 1.6, glucose 58. Liver function tests were within normal limits. Thyroid function test showed TSH of 75, free T4 of 0.2. Arterial blood gas showed a pH of 7.28, PCO2 of 50, PaO2 of 60, bicarb of 24. Cortisol level at the time of the patient's presentation to the emergency department was 12 microgram per deciliter. EKG showed sinus bradycardia, low voltage QRS complexes as well. Imaging studies. On chest X-ray, there was mild cardiomegaly with bilateral pleural effusions. CT brain, no acute intracranial pathology. What are the differential diagnoses? Mixed edema coma, hypothermia, adrenal insufficiency, sepsis, cardiac tamponade are the main differential diagnosis. The final diagnosis is mixed edema coma, diagnosed based on clinical presentation of altered mental status, hypothermia, bradycardia, hypotension, and laboratory findings of severe hypothyroidism with elevated TSH and low free T4. How do you manage the patient? The immediate management includes management of airway and breathing, intubation and mechanical ventilation due to respiratory depression and hypoxia, and support circulatory system with IV fluids for blood pressure control and correct electrolyte imbalances. Vasopressors if hypotension persists despite fluid resuscitation. Thyroid hormone replacement. Combined therapy with levothyroxine and liothyronine rather than levothyroxine alone is recommended. IV levothyroxine at a loading dose of 200 to 400 microgram followed by daily doses of 50 to 100 micrograms. IV liothyronine, also called T3, can be considered in severe cases, starting with 5 to 20 micrograms followed by 2.5 to 10 microgram every 8 hours. Supportive care. Patient needs to be in the ICU setting and needs passive rewarming with blankets. IV glucose for hypoglycemia and corticosteroids like hydrocortisone 100 milligram IV every 8 hours until the possibility of coexisting adrenal insufficiency has been excluded. The patient must be treated with glucocorticoids in stress doses. Monitoring and follow-up. Continuous cardiac monitoring, serial measurements of vital signs, thyroid function tests and electrolytes, and monitor urine output and renal function. Adjustment of thyroid hormone dosage based on clinical response and repeat thyroid function tests. Adjust the thyroid hormone dosage. Treat with empiric broad-spectrum antibiotics until infection is ruled out. Clinical pulse. There needs to be a high index of suspicion for myxedema coma. Myxedema coma should be suspected in elderly patients with non-hypothyroidism presenting with altered mental status, hypothermia, and bradycardia. Infections, cold exposure, medications, and poor compliance with thyroid hormone replacement therapy are common triggers of myxedema coma. Early recognition and aggressive treatment with thyroid hormone replacement, supportive care, and correction of precipitating factors are crucial to improve outcomes. A multidisciplinary approach is effective in management and requires coordination between endocrinologists, intensivists, and other specialists. Long-term follow-up, ensuring compliance with thyroid hormone replacement therapy and regular monitoring of thyroid function tests is essential to prevent recurrence. The following are the reference resources.